So managing patient expectations. So why getting that MRI won't help you get any better? How do we discuss that with our patients? How are we letting them know that actually having an image and having that MRI or having that CT or having that X-ray isn't actually going to solve your pain problems? So thinking about our expectations of our patients. So we expect that they show us respect and trust. We expect that they're punctual. We expect that they're compliant with their treatment or their exercises or what we ask of them, and that they take an active role in their rehabilitation. So that's what we're expecting of them. Now, patients' expectations of us, they expect us to manage and relieve their symptoms. They expect us to be able to give them some self-management strategies. They expect hands-on treatment. They expect us to listen to what they have to say. They expect us to have a patient-centered approach, to think about what they want and what works with their lifestyle. That their advice that we give them is individually tailored, and that we offer supervision and support. We're understanding the physical and emotional impact of pain, and actually we're thinking about their experiences that have been influenced by family and friends. So when we're managing that patient and when we're asking them to do certain exercises, do we necessarily take into account what their expectations are of us? And does that then affect the patient therapist therapeutic relationship? When they're coming expecting imaging or expecting answers, how good are we as a profession in terms of physio, podiatry, nursing profession? How good are we at managing our patients' expectations of us? And how good are we at having those open, honest conversations about what they want from us and what we want from them? So thinking about further specific training. So in day 7, Sarah will talk through having those difficult conversations, talking about managing patient expectations, talking about having those conversations around we're not going to cure your pain. Think about people that you have around you in terms of clinically who can help you with some of the more chronic aspects. So spending time with the pain team to look at their behavioural models in terms of how they manage your patient themselves and how we look at communication styles. So communication is really important so that when we first manage a patient, we're on the same page and we're looking for the same outcome or similar outcomes, and we're able to have those reflexive conversations. So thinking about where yourself as a clinician, where do you lie on that spectrum of being able to reflexively listen to your patients? What hinders us in terms of having those conversations? Is it time constraints? Is it our own beliefs? Do we have preconceived ideas as to what is going to help that patient? And do we always listen to what the patient wants? We can all be guilty of trying to keep within time constraints and having ideas and perhaps not going through individually each step of the process in terms of communication and thinking about um, different ways and different methods of communicating with patients, whereby it may not always be that they're taking on what you're saying verbally. Do we have non-verbal literature to give them? Do we have evidence to give them in terms of what may help them or what has previously helped them? Thinking about where they're coming from. Have they been around the physio merry-go-round before? Have they previously been, so thinking about from a podiatry point of view, have they previously been to see a podiatrist or a GP, or thinking about chiropody, thinking about physios themselves, and that hasn't really helped. So they're coming to you with pain, and they've previously seen clinicians, and you may contradict what somebody else is saying. How do you manage that? So it might be worth having a look at the cognitive behavioural approach to think about how you manage those communication skills. There's also evidence that suggests that surgery rates are highest when imaging rates are higher. So we're going out looking for something and we find something on imaging. So thinking about, we latch on to the fact that this patient has a finding on an MRI or an X-ray, And actually, how long has that been there? Is that the true cause for the patient's pain or the way that they're presenting today? And if it isn't, and we go on to then operate on that patient, the outcomes are going to be really poor because we've not dealt with the ultimate reason as to why that patient has pain. So thinking about general degeneration, thinking about patient's lifestyle, and also thinking about those false positives that come back on MRI scans, on CT scans, on X-rays, um, that actually aren't going to have any weight into what you're going to do clinically with that patient. So in terms of managing patient expectations, do you have training on this? Do you have departmental training where you talk about those difficult conversations? Like I said, Sarah will cover some of the handling difficult conversations in day 7 for you. Are there signs up in the waiting areas regarding imaging that isn't usually required? So showing visual representations of imaging, utilising those patient waiting areas to be able to provide education for your patients. Even thinking about how you feed that into things like your back classes that may be running, or some of your Pilates classes that manage some of the back pains. Thinking about not necessarily just the spine. So if you do X-ray your knee, it's probably going to show degenerative changes. Does that mean that you should stop doing what you're doing or stop doing your exercise? No. And if we actually think about previously, we have been down the route of avoiding running, avoiding impact running, whereas actually there's evidence out there at the minute that suggests that running is, and the compressive forces actually don't provide any greater predisposition to pain as a result of osteoarthritis. So what do we do when a patient requests a scan? How are we going to manage that? So it might be worth just having a think here, just 2 or 3 ideas as to what you would use as a source of information for perhaps somebody who comes in wanting a scan. Where would you direct them to? And how would you show a patient or prove to a patient that actually potentially a scan isn't what's needed?